So like Dr. Nemeth, I do see my fair share of hip clicks, and something else I see quite a bit in my clinic is toe walking or concerns for it. So early onset toe walking, is there a reason to be concerned? So I have no disclosures for this lecture. The objectives for this talk, So the objectives for this talk, we're going to go over gait analysis just a little bit. Talk about what toe walking is as far as a definition, the differential diagnosis, history and red flags, physical examination, terminology, and treatment options, and then finally a summary. So again, there are very large textbooks dedicated to just gait analysis. Just briefly, so there's some familiarity with the terminology I'll use. In the gait cycle, there are two major components. There's a stance phase and a swing phase. The stance phase, or when the leg is on the ground, comprises about 60% of the gait cycle. This is then subsequently broken up into three primary components: the heel strike, or first heel rocker, the limb stance, or the second or ankle rocker, and then finally toe off, or the third rocker. And then the swing phase, again, comprising 40% of the cycle. The initial swing, which is foot clearance, mid-swing, and then terminal swing. Some other terminology you may hear during the lecture, something called cadence, which is basically the number of steps per minute. In other words, how quickly are you picking them up and putting them down. Stride length, which is by definition taking a step with your right foot, your left foot, and then the subsequent right foot step, the length that is covered during that cycle. So normal gait development. So the initial gait, typically the bell-shaped curve, kids start ambulating between 12 and 16 months of age. The initial gait, or what is sometimes referred to as the toddler gait, is composed of a short stride length with a fast cadence and a slow velocity, and sometimes slightly wide-based. In other words, they pick their feet up and down relatively quickly, but they don't go too far. There's also often a lack of a reciprocal arm swing, and their arms are kind of held in a high guard position. And then depending on the age, as Miss Manda talked to you very well about, an in-toeing type gait, either with some mild bow legs, genuvarum, or genuvalgum knock knees, again, depending on the age. So the toddler's gait, again, kind of the same that I was discussing before. The range of gait in toddlers is incredibly broad. The initial gait may be a toe-toe gait. It might be a flat foot type gait, or a heel-toe type gait. And again, it's typically slightly wider than the adult. Again, the arms in the high guard position. So last year, if any of you were here, we had a lecture by Dr. John Davids, who's very good at gait analysis, and they have a very nice gait lab. He had some wonderful slides and images. We do not have a gait lab at Louisville. I have free labor children, and I have my kitchen. So this is one of my I have 2.5-year-old twins. This is one of them, and so he was probably about 16 months at this point. So I'm just going to let you watch his kind of gait initial, and then I'll kind of go through a couple parts of it. So. That's his twin, probably about to tackle him or take him out. But anyway, so as you watch him walk away, okay, I think it's a very nice example of how you can see he's kind of up on the toes. He's up on both toes, and then as he kind of goes around the corner, he tends to flatten back out, and then he comes back around. He kind of demonstrates that as he goes around, again, he kind of flattens back out. As he comes back around, kind of back up on the toes, arms up in that kind of high to arm position. The feet are going up and down relatively quickly, although he's not advancing all that quickly. And that is kind of your standard toddler gait or initial gait. Nope, sorry. So what is toe walking? So typically the definition of idiopathic toe walking or toe walking is the persistence of a primarily toe walking gait or a toe-toe gait beyond the age of 3 years. Most toddlers, again, will experiment with the different walking techniques, but children will typically acquire a more heel-toe gait by the time they're about 3. The two most common causes of toe walking are idiopathic and spastic diplegic cerebral palsy. And as you can imagine, the outcomes and treatment can be relatively significantly different. So as I mentioned before, idiopathic and CP are your two primary causes of toe walking. Besides CP, other neuromuscular disorders such as spinal cord anomalies, dystonia, or a peripheral neuropathy, paralytic muscular diseases, muscular dystrophies such as Becker's or Duchenne's, orthopedic manifestations, as Dr. Nemeth pointed out, as the patient presented with a toe walking gait and had unaccounted for dysplasia or leg length discrepancy. And then it has been associated with behavioral disorders such as autism, and I'll get a little bit more into that later in the lecture. So as far as trying to decide what the etiology of the toe walking is, the history can be an important part of trying to decipher the diagnosis. Establishing a time course can be very helpful. Early onset toe walking usually occurs within 3 months of the initial onset of ambulation. And so that's, for me, especially when it comes to idiopathic toe walking, hearing that they kind of have always done it as part of their initial gait is usually somewhat reassuring, in that it's often associated with idiopathic. A late onset toe walking gait can be concerning for a neuromuscular process, specifically with like a muscular dystrophy, where they were not toe walking when they first started ambulating and then developed a more toe walking gait, especially if that's associated with weakness. And again, the persistence of a toe walking gait after the age of 3 and certainly asymmetrical patterns should be further investigated. So history, red flags, and I guess if you take nothing else away from this lecture, the first 2 bullet points are kind of the key for me. So idiopathic toe walking, or in other words, they toe walk because they toe walk, is always bilateral, always. Unilateral toe walking, such as the case of Dr. Nemeth's hip dysplasia case, is never idiopathic. Whatever the etiology is, it's not idiopathic. Weakness or poor stamina with toe walking, again, could be a sign of a neuromuscular or muscular dystrophy type of etiology. And then a history of prematurity, developmental delay, family history can suggest underlying neurologic etiology. The family history, not of toe walking, but of other neuromuscular pathology. So physical examination, again, no one is expected to be an expert in gait analysis, but it's I think often kind of looked over when you're doing your brief musculoskeletal exam to just have the patient walk in the examination room. So looking at the gait itself, again, acknowledging if it's unilateral or bilateral, how symmetric is the toe walking? Are they on their toes, but one more than the other? And then can they walk heel-toe with verbal cues, or if you ask them to? The ability to rise from a seated position, again, just looking for evidence of weakness or some underlying neuromuscular pathology. This is, as you may have recalled, Gower's sign, where as opposed to being able to rise without needing their upper extremity, they kind of have to crawl and walk themselves up their body using their upper extremity. And then the ability to run. So I mentioned that diplegic CP is high on the differential diagnosis, or at least the second most common. When it is hemiplegic cerebral palsy, or affecting one side of the body as opposed to the other, if it's mild, that can sometimes be relatively challenging to pick up, or it can be very subtle. And for some of these kids, especially if they're a little older, they're pretty good at hiding it. But if you ask them to run, often when you ask them to run, they cannot not posture their upper arm on the affected side, which can kind of be a giveaway in those cases. Physical examination, again, you're looking for atrophy or possibly hypertrophy of the extremities. Spine and skin examination, cutaneous signs for neuromuscular pathology, hemangiomas, tufts of hair, or a large sacral dimple. Foot examination may show a cavus deformity or a claw-toe deformity, again, potentially suggesting a neurologic etiology. The posterior calf muscles with an idiopathic toe walker can be a little bit more developed, but the texture of the muscles should feel normal as opposed to in the case of muscular dystrophy, where they kind of have a fibrous texture to them. On the bench examination, you're checking for ankle plantar flexion and dorsiflexion, in other words, putting the ankle down, lifting the ankle up, and then something called silver skill maneuver. And what that essentially means is you are testing how far you can dorsiflex or bring the ankle up with the leg both in an extended and a flexed position. What you're doing when you do that is you are checking for tightness in both the gastrocnemius and soleus complex, in other words, the muscles, and then when you flex the knee, you somewhat take that out of the equation and you're checking for how much tightness there is in the actual Achilles tendon. Hips and knees should also be evaluated for any evidence of contractures or tightness. The neurologic examination for this, again, you're checking for deep tendon reflexes. I always check abdominal reflexes as a part of that, and then plantar and stretch reflexes. And then again, an abnormality in the reflexes could avert you to a possible neurologic cause. And then on the physical examination, checking for things like spasticity, clonus, and the Babinski test. So what are those? For spasticity, that's a velocity-dependent increase in muscle tone with increased spastic tonic stretch reflex. So in other words, when you go to check how much you can dorsiflex the ankle, if you do it rapidly, if in a case with CP, what you'll get is an immediate tightness or resistance to moving the ankle. Then as opposed to if you slowly apply pressure to that same ankle, if they have spasticity, you can often get significant increase in range of motion by doing it slowly after you overcome what we call a dynamic resistance or that spasticity. So what seems to be a rigid plantar flex ankle can sometimes be brought up to 10 degrees as long as you do not do it rapidly. Clonus is a rapid succession of alternating contractions and partial relaxations. So what does that mean? So with ankle clonus, or what you're doing is you, as if you were checking for spasticity, you dorsiflex the ankle quickly, and when you do so, that can elicit several beats of the foot ankle. And most textbooks would say that 2 to 3 or 4 beats of clonus is considered normal. More than 4 beats, based on our neurologists, would say is abnormal. And then the Babinski or plantar reflex test, you, from the bottom of the foot, going posterior to anterior or back to front, you do tactile stimulation on the plantar surface of the foot. And then the big toe flaring up would be concerning or consistent with an upper motor disease if that is found on a child beyond 1 year of age. An upward flare of the toe before 12 months of age is considered normal. So idiopathic toe walking features, for whatever reason, predominates in males. Now, I think that number might be skewed a little bit because I think there are probably a significant number of females who can, if they were never treated or diagnosed, can hide it with just simple use of heels. But at least the data we have, it's primarily in males. There seems to be a family history of it. Previous studies have noted associated history of prematurity and developmental delay in idiopathic toe walking, which is not really a surprise. And again, it always occurs bilaterally if it's idiopathic. And as long as there's decent flexibility, they can typically walk heel-toe or flat-footed with verbal cues. I'll get into this a little bit when I'm comparing toe walking idiopathically versus CP, but they have the absence of what we call like a back knee thrust when they walk on their toes. I wanted to have a video of that. I apologize, I don't have time to get that in there. So spasticity, as I mentioned before, it's a velocity-dependent tightness, and the it's usually the result of damage to the corticospinal tract at any level of the motor cortex to the spinal motor neuron. The most common cause of spasticity is CP, usually due to a perinatal brain injury. The mechanism for toe walking in that case is spastic contracture of the heel cord. So again, some of these are just acknowledging that there are significant physiologic differences as to why these kids toe walk if you're looking at idiopathic versus diplegic CP. So in cerebral palsy, they have a decreased velocity, a decreased stride length, and again, that's the distance covered in successive steps taken, and then an increased duration of the double limb support in CP. In other words, the stance phase is increased, and there's actually more crossover in what would be double limb stance. And this is based on gait analysis studies. The gastrocnemius soleus muscle activity is what's called out of phase in CP as opposed to being in phase in idiopathic. And again, that's based on gait analysis and EMG studies. There's greater sustained knee flexion at terminal swing, and I was actually considering trying to demonstrate that, but I think unless you're sitting in the front row, I'll just look like I'm walking back and forth. So, but essentially, as I mentioned in the earlier slide, since they have greater sustained knee flexion at terminal swing, the maximal knee extension is mid to late stance in toe walking for CP. So in other words, as they are on their toes, as they are coming forward, you can sometimes see a subtle back thrusting or the knee going backwards as they walk. And it almost looks like their posterior is sticking out a little bit as they walk. I've heard Dr. Jacks refer to this as kind of a poochie butt type of gait. I don't think that's been coined yet, so you can hold on to that. But that's, and again, it can be, it's fairly obvious when they're more severe, but it can be really subtle if it's a mild diplegic. I'm going to go through this a little bit quickly. Again, the take-home point with paralytic muscular disease or some type of muscular dystrophy like Duchenne's, there's a weakness involved, and oftentimes the toe walking in those instances will be kind of a late onset where they maybe had late onset of walking in general, or at least close to delayed with 18 months, and while they were initially kind of a heel toe or flat foot gait, they didn't develop a toe walking gait. Orthopedic manifestations, again, unilateral toe walking always warrants further evaluation. If it's a leg length issue, you can sometimes see what would be described as a circumduction gait, where the shorter side, or the longer side is literally swung out to the side during the swing phase portion of the gait. Behavior. So toe walking pattern may be observed in children with neuropsychiatric disorders like autism. So one study found that 19% of children diagnosed with autism exhibited toe walking for a minimum of 6 months. And I think what's important, especially when you have, at least when I see these parents, is while children with autism have an association of toe walking at some point during their life, a child with toe walking does not have a significant chance or an association with autism. All right, so in other words, the inverse is not true. I think what's, and as far as that study goes, those children, all of them walked on their toes only intermittently, and reduced ankle mobility, in other words, tightness in the ankles, was relatively rare. And so, and this last study, again, I think I mentioned earlier in the talk, children with idiopathic toe walking have more neuropsychiatric problems than a normative group of age-matched children. How helpful that is, I don't know. Besides acknowledging that children who toe walk don't necessarily have autism, but children who have autism may have an increased risk of toe walking, I think another big take-home point here is that if you have a child in your clinic who has autism and the parent is concerned about toe walking, you don't just say, oh, well, they have autism, that's why they're toe walking. Children with autism can have cerebral palsy. Children with autism can have hip dysplasia. Children with autism can have a leg length discrepancy. So it doesn't mean that the exam is done. Those kids deserve their evaluation as anyone else would. So a more controversial, I guess, topic would be, is treatment for idiopathic toe walking necessary? And the literature currently would suggest that as long as if it's idiopathic, if the children have more than 5 degrees of passive dorsiflexion, in other words, when you try and take their ankle and you can bend it up past the neutral position at least 5 degrees, and some would say 10 degrees, persistent toe walking or toe walking as a gait is not a functional problem. In other words, they have the flexibility in their ankle joints that it should not cause problems either with the bones in the feet or function in general. More severe contractures can lead to orthopedic problems or manifestations like forefoot splaying, or in other words, widening of the or spacing of the bones in the feet. External tibial torsion and foot pronation can also develop. And again, without getting into specifics of gait analysis, this has to do with how the bones in the feet and some of the muscles act when you first hit the ground on walking with heel strike and limb stance. And in order to achieve a more plantigrade or flat foot stance when you walk, if you have tightness in the back of your, if you have tightness in either the heel cord or the muscles in the back of your leg, to achieve a more, to achieve getting the foot on the ground, you can sometimes cheat it, so to speak, by turning the feet out. So sometimes with toe walkers, especially if they don't want to be treated, they will, to try and walk heel toe, you will see them turn their feet out to a relatively impressive external angle. And then development of a midfoot break to permit contact with floor is often seen in neuromuscular conditions, but it's atypical in idiopathic toe walking. In other words, with neuromuscular toe walking, where they have contractures and cannot walk heel toe with verbal cues because of the alignment of the bones during the gait cycle, they can develop a break in the bones of the midfoot. So treatment options that are currently available, usually for me, especially if there's decent flexibility, it'll start with just stretching and strengthening at home. For when you're doing the physical examination, I think it's important, and I apologize for not mentioning earlier, when you're checking the dorsiflexion of the ankle, you want to have the back of the heel or the hindfoot swung in. So again, I usually start with home stretching and verbal cues, and then if that's not getting you quite where you want to be, I usually add physical therapy, and then plus or minus bracing or orthotics for kind of stretching at nighttime. Some of those are just two braces that I have used in the past. I've started to use the posterior leaf spring orthotic or PLSO more, essentially because it's usually better covered by insurance and is a little bit less expensive. And then from there, it's serial casting, where you try and get the foot into a more neutral position. We usually change those casts out every 1 to 2 weeks. Following casting, I usually put them in some type of bracing. One author recommended full-time for 3 to 6 months. I don't know that I do it quite that long, but I usually do some form of bracing if we're to the point of doing serial casting. Botulinum toxin injections with serial casting, that is definitely something that we do in our clinic. I should recognize that how effective that is has been recently called into question. There was a paper in 2013. I think it was it was either JBJS or Journal Peds Ortho, but there was a randomized control study where they looked at Botox injections with serial casting versus just serial casting. And in that paper, they found that there was no significant difference in outcomes whether you used Botox or didn't use Botox. With that said, I have definitely had patients who we attempted serial casting in, and they simply could not tolerate the casting because of the tightness. And those patients I've sent to either Dr. Jacks or Dr. Chan, and with use of botulinum toxin injections, they were able to tolerate the casting and had relatively decent outcomes. Surgical treatment, kind of the last step, at least as far as in our clinic, and that usually involves some type of heel cord lengthening. And I mentioned before, as long as there's maintained flexibility in the ankles, there's usually not a long-term functional problem. If you have toe walking beyond the age of 6 years with heel cord contractures, that can lead to complications, as I mentioned before. So, in summary, idiopathic toe walking, it's a persistence of the toe-toe gait by definition beyond 3 years of age, and it's a diagnosis of exclusion. The two most common causes are idiopathic and spastic diplegic CP. The differential diagnosis includes neuromuscular disorders, paralytic muscle diseases, orthopedic manifestations, and behavior disorders. Red flags, unilateral toe walking, weakness or poor stamina with toe walking. A history of prematurity, developmental delay, or milestones can suggest underlying neurologic etiology. And then again, treatment for us, it consists of conservative and surgical interventions. And again, there have been groups who have suggested or going right to surgery to treat these kids for idiopathic toe walking. And while it can be an effective means of treatment, the weakness that is the result of treating these kids surgically or releasing the heel cord or lengthening the heel cord, that weakness can be present for a relatively significant period of time. And again, while it can be effective, if that is something that's utilized, you really have to warn these parents that they will go from a toe walking gait to a relatively flat and very different looking gait, hopefully not a crouch gait, but and a high recurrence rate. So whenever I see a patient with toe walking, I always inform the family right up front. It's one of the most challenging things I see. The metaphor I use with idiopathic toe walking is always the same. It's that because parents want to know, why do they toe walk? And the analysis I use, it's like asking, why are they right-handed and not left-handed? That's just kind of how they're wired. So in terms of treating it, I think the metaphor still applies. Can I make your child left-handed instead of right-handed? I can try. We can do things like cast the dominant arm, do therapy to use the left arm, have them hold the right arm behind their back, and if we do that for several weeks to months, there's a good chance they're going to start using the previously non-dominant arm more dominantly. But if we do that for several months and then we stop all treatment and then we see them again 6 months later, chances are they have gone back to using the previously dominant arm. So if you do start treatment for toe walking, especially in idiopathic, you have to let the parents kind of know up front that there is a kind of a maintenance treatment that has to kind of go on at least until the point where the kid cares what they look like when they walk. Your 4 or 5-year-old does not care at all what they look like when they're walking. So until they do, again, there's kind of a maintenance phase of treatment. So this is my same toddler here, and it's sometimes still used, but having these kids wear kind of high top shoes or large shoes, or extra large shoes in this case, by putting them in that, they can't walk on their toes. I have not patented this treatment, but it's effective. It's effective. I like it. So these are all my references, and thank you very much. Thanks.